This podcast series is brought to you by Not Defined by Endo, providing support to endometriosis patients, their loved ones, and anyone suffering from symptoms that they suspect to be caused by endometriosis. This episode is sponsored by Totesphere, sustainable merchants in the UK who sell products that are good for you and good for the environment.
Hello, and welcome to episode 2 of Endo 101, a mini-series that seeks to inform and educate on the enigma that is endometriosis. My purpose on this mini-series is to talk about all the aspects of endometriosis, right from proper definition to treatment methods and even to myths that are pandered about the disease. I am so privileged to be joined today by Mr. Thomas Bainton, the Endometriosis Fellow and a Senior Registrar in Obstetrics and Gynecology at the Chelsea and Westminster Hospital in London, UK. Today, we are talking about all the colours, the stages, and the sites where endometriosis can be found. If you have any questions you are keen to get answers to, send an email to info@notdefinedbyendo.com with your questions, or DM me on Instagram at notdefinedbyendo, or Tom at ccmig.london. If we have enough questions, we just might do a bonus episode where we answer them all. Welcome back, Tom.
Thank you, Tenny. Absolute pleasure to be back again.
Yeah. So let's jump right into it. Last episode, we discussed the theories of endometriosis, the definition of the disease, and why it is such a complicated disease. And we even discussed the common and even less common symptoms. So are we ready for episode 2?
I think so. One we learned from last time is we could talk about this all day. And I gather in the chat with you before that we had about twice as much material as we were expecting to edit down. So we'll try and be more succinct, shall we, this time? But we'll see how we get on.
Yeah, let's do it. Okay, so I've got this question that I have been thinking about since we finished episode 1, and I really wanted to talk about it. You mentioned that under a microscope, there are differences in the structure of endometriomas, peritoneal endometriosis, and deep infiltrating endometriosis. You said that it could actually be considered that these are all different diseases in their own right. So can we talk about what each of these forms of endometriosis are and why they could very well be seen as different?
Yeah, I think you're absolutely right. I think the key differences really are in the theories about how they got there to start with. One thing to say, right off the bat is that they're all endometriosis to all intents and purposes. They have similar characteristics in the pathological finding of endometrial glands and stroma, which is those cell types that live in the lining of the womb normally, but outside the womb. So they've all got lots of sort of consistent findings. But you're absolutely right. And I think we talked about it a little bit last time, didn't we? They do have fundamentally different characteristics. They present in different ways. They seem to happen to different people, and they look quite different under the microscope. And there may well be very different theories about how they each started. We don't know for sure. I think probably the most different characteristically is the deep infiltrating disease. And there's more and more evidence now to say that, that's probably got a different origin story, what we call the pathogenesis. The cell types look quite different under the microscope, and certainly the areas around the actual endometriotic cells look quite different too. The deep infiltrating disease, we classically say a deposit more than 5 millimeter depth beyond the peritoneum, retroperitoneally, and that's in the rectovaginal septum between the vagina and the back passage, the rectum, or on the uterosacral ligaments, which are the ligaments that attach sort of the bottom of the uterus right onto the cervix to your sacrum, which is the bone at the bottom of your spine, and in the pelvic sidewall. And this area is often underneath an ovary, and it can go down towards the ureter, which is the tube from the kidney to the bladder. So those are the sorts of areas that people might understand from reading their surgical reports and also talking to surgeons about what are the risks of removing it, because a lot of the risks of surgery are associated with damage to areas around where we're operating. When we look at a nodule, and you might find a nodule that's 3, 4, 5, 6 centimeters behind the uterus, or on the uterosacral ligaments or similar, not all of it's made up of that endometriotic tissue. You see that you've got the endometrial glands and stroma, but surrounding it, you've got smooth muscle cells, you've got fibrotic cells, and lots and lots of scar tissue and other inflammatory areas and new blood vessels forming, which we simply don't see in the peritoneal or ovarian disease. Which leads us to think, is this peritoneal disease that started off in that position and over time it's changed, it's become something else? Or is it actually something else fundamentally to start with? And I think it probably is more on the side of being something else fundamentally to start with. We also know that when we find someone with peritoneal endometriosis, or we find the presence of peritoneal endometriosis, which often exists together with the other types, if we did a laparoscopy and looked, it doesn't tend to be progressive. So we see the peritoneal endometriosis on day 1. We then look again a year later, 2 years later, 10 years later, it's still peritoneal endometriosis.
Right.
And it's also true to say that if we see someone when we first diagnose deep infiltrating endometriosis on day 1, we look again year 1, year 2, year 10, it doesn't tend to actually have changed a huge amount since the first diagnosis. So it seems that endometriosis, it looks like how we found it and doesn't necessarily change a huge amount. If they were all one type of condition or exactly the same cell type and exactly the same pathological process going on, then we would probably find more and more cases where the peritoneal endometriosis actually became something much more significant over time. Ovarian endometriosis, we know, does change, and those cysts grow, and we can remove them, and then we can watch them recur, and sadly they do have a recurrence rate. We look at about 20% at 6 months, which is really high, and we see them grow and develop over time. It's probably to do with some of the endometriotic area, some of the cell types that make up the cyst just staying around behind after excision, and then the ovary refilling with that chocolate fluid and it growing over time. So absolutely, I think that we can look at them as being fundamentally different things, in that different women suffer with one more than the other. Some might have deep infiltrating endometriosis. They often have it from day 1. They often have it with ovarian endometriosis and peritoneal endometriosis. But someone who we find peritoneal endometriosis might not necessarily develop one or the other. And we sometimes see ovarian endometriosis entirely on its own. Again, there's a difference within each flavor. We see the ovarian endometriosis, the endometriomas. If it's an isolated ovarian cyst that's in an ovary that's otherwise nice and free and mobile in the pelvis and not stuck down to any of the structures around it, there's no adhesions, then actually there's not that great a correlation with having the deep infiltrating disease. But if we see the ovarian endometriomas and they're stuck down, they're stuck together, they're pulled behind the womb, people might know from ultrasound reports and MRI reports, we often talk about kissing ovaries, which is a far nicer way of putting a really quite tricky condition. But if we see that the ovaries are kissing together behind the womb, stuck together, then the chance of having the deep infiltrating endometriosis with it is far higher. So there's definitely a correlation, and one can relate to the other. But I think thinking about them as different cell types is useful.
Okay, interesting. So could any of these types of endometriosis predispose women to any types of cancer?
Yeah, and this has been looked at quite extensively. And it's important to say, if there is a relationship between endometriosis and an increased risk of cancer, then it's small. We don't view it as being a massive risk, but there are some things that are far more higher risk for getting cancer, namely family history of breast or ovarian cancer, or endometrial cancer being a significant one. Certainly BMI, being overweight vastly increases your risk of getting endometrial cancer. So, those risks are actually substantially higher than any risks we might observe in endometriosis. But there have been some studies that show that women are sadly at a slightly higher risk. The ovarian endometriosis particularly, there's lots of different types of ovarian cancer that can develop. People might have read about ovarian cancer being a very difficult condition to diagnose in the early stages, and it can be quite scary because it often presents fairly late in its course. There's a view in the oncological world, in gynecology, actually early ovarian cancer has no symptoms whatsoever, so it's difficult to see and pick up. Ovarian cancer has been observed in patients with endometriosis. There is a type of ovarian cancer, called clear cell, which is one that particularly endometrial ovarian cysts can become. It can also become the endometrioid type. So it's the type of cancer we see in the lining of the womb that can happen in endometriosis elsewhere. And there are indeed case reports of women who've had treatment for endometriosis, including a hysterectomy. You would think you've had your hysterectomy, the chance of getting womb cancer in later life is gone down significantly, which it has, but very, very rarely. And I think, we are talking about hen's teeth here. Endometriosis that's outside the womb could, over a lifetime or decades, potentially become malignant, become cancerous thereafter. So it's always something to be aware of, and your doctors to be aware of in future life. Yes, you had a hysterectomy for your endometriosis in your 30s or 40s, but actually if you were shown to have significant sized endometriosis deposits elsewhere, that could be a risk. But I think, I want to emphasize that studies have found different things. Some studies have found a slightly increased risk of ovarian cancer. Some studies have found no increased risk at all. So we don't classically think about it as being something that changes the risk substantially. And the time at which endometriosis affects women, usually during younger reproductive years, the risk of getting cancer at that stage is similarly incredibly low.
Okay.
One thing I think that is important to say is that a lot of women, when they're first diagnosed with endometriosis, there might be a bit of a question mark over it. Because when we're looking for signs and symptoms of ovarian cancer, what do we see? We see bloating, we see pelvic pains, we see change in bowel habit. All of those might sound quite familiar to people who suffer with endometriosis. And then you might have some investigations to your GP, and they'd probably organise a pelvic ultrasound and a blood test called a CA125 as the first line. Pelvic ultrasounds and endometriosis might well find ovarian cysts. They might find what we call complex ovarian cysts that look like there are lots of locules within them, or they're stuck to structures around them, or they're on both sides, or there's some free fluid in the area. A CA125 blood test, which is a blood test that's done to try and tell us whether we should be worried about an ovarian cyst or not in context of cancer. Most significantly, it's important in the postmenopausal age group. So actually, we're dealing with a very different group of people to women who suffer with endometriosis. But it is a test that it's right to say is raised in women with ovarian cancer. But there's also 101 other causes for it to be raised. So although it's quite a sensitive test for ovarian cancer, so if you have ovarian cancer, it's very likely the CA125 will be raised. It's not a particularly specific test for it.
Okay.
So if you've got a raised CA125, there are 101 different things that could be going on, one of which is cancer of the ovary, or actually probably if you're looking at the statistics, far less than one of which is cancer of the ovary in a premenopausal woman. So I think it's useful that people know that if they have got an ovarian cyst and a raised CA125, that doesn't necessarily mean that it's things like cancer. But in the modern age and in medicine, we often talk about things in that context, and we want to rule that out as a first port of call. We sometimes see patients in our endometriosis centre at Chelsea who've actually been discussed at our cancer meetings first. So they have a cyst that looks a little bit suspicious, and they've done a blood test and found the CA125 to be elevated. But actually, when they look at the pictures more carefully, or maybe do a pelvic MRI to try and get to the bottom of things, and getting a history from the woman about her pains and how she's experienced things, actually the chance of cancer is much, much lower.
Okay. Well, that's good to know that there's no direct, having endometriosis does not necessarily predispose you highly to cancer. So.
Exactly right. So different studies have said different things, but broadly speaking, I think that's correct.
Okay. Another thing I had in mind was in relation to the names of contributors to the theories and research done about endometriosis, which we talked about last episode. So we talked about Thomas Cullen, Rokitansky, and even John Sampson, who was responsible for the theory of retrograde menstruation. But one of the names we didn't mention was David Redwine. He has been credited with the theory of mulariosis as being a cause for endo. And you talked about it as having endometriosis being found in embryos. So I just wanted to know if there's any information by Redwine that you want to share so listeners know a bit more about why his work was so relevant to endometriosis. I've been hearing, a lot has been said about him. I've heard about him in, Nancy's Nook Facebook group and a few other people in the community of endometriosis.
Absolutely, yes. He was an American doctor, and his theory stems from the fact that, the retrograde menstruation just has lots and lots of holes in it. I mean, we all know that we see retrograde menstruation in the majority of women, and we don't see endometriosis there. We also see endometriosis in the absence of retrograde menstruation. We might even, if you scour through the scientific literature, you'll find evidence of endometriosis in men, for goodness sake, or women without uteruses. There are some genetic conditions where women sadly are born without having a womb. And they, of course, don't have retrograde menstruation because they're not having periods. So there's got to be something else going on, right?
Yeah.
This links back into talking about all those different sites of endometriosis potentially being different diseases. And most of what red wine is talking about is deep infiltrating endometriosis. So we're not necessarily talking about the superficial endometriotic deposits. We're talking about the deep deposits that are invasive into the areas around them, classically found on the uterosacral ligaments, the pelvic sidewall, and the rectovaginal septum. So melariosis describes the deposition of this endometriotic cell types and tissue along the areas where the reproductive tract forms in a woman. It happens in both women and men, actually, that the gonads, so that's the testicles or the ovaries, start off when we're a tiny little fetus in the first few weeks and months of our development in the womb. They start off by our kidneys, which are sort of just at the bottom of your rib cage around the back. So if you feel the bottom of your ribs just a little bit lower, both sides at the back, that's where your kidneys live. And over a period of time, the gonads move down that tract and they leave little deposits behind in certain groups of people. Some people have cysts all along these tracts. And it could be that in those areas, we see tissue types that would normally be found in the lining of the womb. So that's the sort of the fundamental basis of it. And it fits quite nicely with the sites that we see endometriosis. They work their way down the pelvic sidewall, down the uterosacral ligaments and into the rectovaginal septum. And then the ovaries, form there, and then the womb forms there in the middle. We talked about, and red wine references this quite heavily, the fact that endometriosis can be found in both fetuses and newborn babies. These are sadly newborn babies who are usually born stillborn, and they've undergone post-mortem examination, which has allowed doctors to be able to find evidence of these cell types. So we've learned a little bit more about it, despite the sad circumstances. Different theories exist. So one is that these are deposited there in the process of the genital tract forming and the cells moving down. It is also, and I think we talked about it briefly last week as well, that there may yet be some retrograde menstruation in those fetuses associated with the maternal, so the mother's progesterone levels, which are very, very high during pregnancy. That causes a reaction in the cell type that's lining the womb, which is a similar reaction to what women get in the second half of the menstrual cycle, which is a preparation for a potential pregnancy, if you conceive during that, after that ovulation. And there could theoretically, again, it's all theoretical, we don't know 100%, be some retrograde menstruation happening at that stage, which kind of primes these cells. And different, or cells in different places, are exposed to different environmental conditions. So an endometrial gland cell in the endometrium is quite happy there, and it's going to do its normal thing, and it's going to grow in the first half of the menstrual cycle and stabilize and secrete in the second and shed during a period. But actually, an endometrial cell which has found its way somewhere else or was deposited somewhere else is under a very different environment. And in that environment, its genetics are going to fundamentally change. Not the primary building blocks, the DNA is going to stay the same, but how it's expressed is changed due to the level of inflammatory markers around it, whether genes are switched on and off due to different processes. There's a process called methylation, which is a chemical change in the DNA. There's a process called glycosylation, which is adding various chemical groups. And all of that plays its part to say, actually, you know what, I'm not going to be a normal endometrial cell. I'm going to invade into this peritoneum. I'm going to get my friends to join me. And then the body says, right, I'm going to try and fight this off. And I'm going to send inflammatory cells here. And I'm going to create new blood vessels and deposit scar tissue in this area. And that process happens over a period of time. And then lo and behold, we get deep infiltrating endometriotic nodules, which the more we look for, the more we're seeing. And we're seeing in women younger and younger and younger. And, you know, I said that earlier on, most women, when we find deep infiltrating endometriosis, it actually doesn't change over time. We find it at a certain level and it stays like that, and until we do surgery on it, if that's what the woman wishes for. And actually, we could find this earlier. We could find this during adolescence when it's first developing, or potentially develop some kind of treatment for it, whether it's hormonal, whether it's immunomodulatory, using medications to try and stop the body's reaction to it, or whether it's surgical, there might be new treatment strategies. So it's very useful to think about the way endometriosis can establish and different theories on it, because it's all potentially going to help guide future therapies. So another thing that Redwine said, he was talking about the Müllerian tract being the areas that endometriosis can potentially deposit in its way down during the embryonic phase and fetal development. And he was a proponent of surgical excision, radical surgical excision of all of this Müllerian tract. And actually then we can either prevent endo or cure it. You're not going to develop the deep infiltrating disease if you haven't got the tracts where it develops. Or if we remove all areas that endometriosis can potentially develop, or is already there but we haven't seen it yet, then we've got a much lower risk of quotes unquotes recurrence. It might be it was always there, it's not a recurrence, we just didn't see it the first time around. Of course, the downside of that is, as women listening to this will know who have had surgery, you feel worse before you feel better, and the more extensive the surgery, potentially the longer the recovery and the more the downsides. Most of what we try and avoid doing in surgery is damaging areas around where we're operating, and there are quite key parts in the Müllerian tract, most significantly the urinary system, the ureter, major blood vessels, important nerves as well, and the collateral damage of doing that and doing very extensive radical surgery could potentially put women at risk and make things, I wouldn't want to say worse off, because it all depends on what the symptoms were to start with, but anyone considering that sort of operation has to carefully balance up, together with their surgeon, together with all the information, the risks and benefits. And it might be that actually medical treatments, hormonal treatments, or less extensive surgery are preferable, accepting that you might not have total excision of disease. There are some proponents saying, actually, no, go for total excision. Let's treat it like a cancer. Let's chop out everything we can see, and then we're going to cure it. And as surgical techniques get better and better over time, then that's going to become more and more possible. In the old days, before laparoscopy, by far and away, the biggest thing to recover from surgery was a great big scar in your tummy. And to do extensive surgery like that, we're talking about, 10, 15 centimeter scars on the tummy, which require a lot of surgery. Laparoscopy is now moving on to the dawn of robotic surgery, which is becoming more and more prevalent in gynecology, and it enables us to operate on finer things with much finer tolerances. I suspect in 50 years' time, I probably won't be working in 50 years' time, but I'll look back in my retirement at what I was doing as a surgeon today and what we're doing in the department today, and think, God, we were brutal. Look at what we were doing, analogous to field surgeons, doing amputations without anesthesia in the Napoleonic Wars. I'm exaggerating, of course, but there will undoubtedly be progressions which might enable us to do things like that.
Yeah, let's hope that happens sooner than later.
Yeah, but then again, it might be that over time we develop gene therapies and novel immunotreatments, and the days of the surgeon are over, and I'll be retiring early because there'll be no one to operate on anymore because we've cured everyone with an injection at birth. Who knows?
I think the first thing we need to sort out is a way to diagnose it without surgery, because right now, I guess, the gold standard of diagnosis is basically like a laparoscopic surgery. So if we can get like a diagnostic marker or test or something that, without going into the patient, you can already tell that the person has endometriosis, I think it would
100%.
And it will help
absolutely.
and it will help to reduce those diagnosis times 7 years to 10 years. So.
Quite right. We talked about finding it early, finding it in adolescence, finding it before it's become a big issue, because it might be women don't get diagnosed until, we know sadly in their late 20s, 30s, or that it's when they're trying for a baby that things are found, when actually the opportunity for treatment and preventing years of all this pain and intolerable symptoms could have been when they were 13, 14. At the moment, I, as a surgeon, I'd be quite reticent to operate on someone at 13, 14 and going later into adolescence. There are risks of surgery, and it's not something you should go into without accepting all the pros and cons. And it could be the beginning of a tough road if you're having your first laparoscopy in your teens. So that is a big stumbling block. I think that plays a huge part in the delay of presentation to diagnosis.
Yeah. Okay, let's talk about stages of endometriosis. So many of us in the community are aware of the American staging system, But we also know that the stage of endometriosis, using that system of staging, doesn't necessarily correlate with the pain or the other symptoms that you experience. Another shortcoming or shortfall of this is that it says nothing about extrapelvic endometriosis, which we'll talk about in a bit. So can you discuss these stages and how they can be recognized, or how you can understand what they are?
Yeah, so the American Society of Reproductive Medicine criteria talk about 4 stages of endometriosis: minimal, mild, moderate, and severe. And it's basically a cumulative scoring system based on what you see at laparoscopy. So it's not something that you can definitively describe before the laparoscopy, whether it's, MRI or ultrasound, but you can make a very good judgment. You get different points based on where it is and how deep it is and the level of scar tissue around the areas of concern. It was developed in the 80s, and it's quite well understood. And I think the key advantage of the ASRM is that doctors understand it, patients understand it, and it sort of makes sense in an anatomical way. So people can look at diagrams and think, that kind of fits with what I'm getting. This is where my adhesions are. I won't go into sort of full detail describing how the scoring works and what it adds up, but I would suggest if you Google it, you'll find lots and lots of diagrams that you can look at and correlate that with your own experience and ultrasound reports and reports of laparoscopies. There are, however, downsides. You're absolutely right to say it doesn't correlate particularly well with the symptoms people experience. And that's true of all endometriosis. I think I talked about it last time that we sometimes do laparoscopies for other reasons entirely. We're investigating, we're doing an appendicectomy or an ovarian cyst that isn't an endometriotic cyst, or sterilizing someone, clipping fallopian tubes so she won't get pregnant without taking hormones. And we see endometriosis and we say, well, did you have pain? Did you have any symptoms? And actually, no, I had no idea. I'm glad I know now, but that hadn't been something that was affecting my life. Sometimes we see it and they say, God, yeah, I had really heavy, painful periods my whole life and it was never looked at. But it doesn't correlate that well with symptoms. And occasionally, and there's a few women I can think of who I've seen recently in clinic, have got, I would say, surprisingly severe disease. We see that they've got deep infiltrating disease, stage 4 on the ASRM, rectovaginal nodules even, and their symptoms aren't that significant. It's rare we see them with no symptoms at all, to be honest. But it's the sort of thing we might find when going through subfertility investigations. So there are pros and cons. It sort of makes sense. It makes sense anatomically, but it doesn't match that well with symptoms people get, nor does it match that well with fertility prospects necessarily. There are a couple of other scoring systems that we use, and they're used variably by doctors and patients. There's one called the Enzian criteria, which, you're right, does include endometriosis found outside the pelvis. It's a little bit more complex in terms of it's just talking about deep infiltrating disease, but it talks about deep infiltrating disease either being in front of the womb, behind the womb, or the pelvic side wall. And then it's in reference to how big the lesion is. So it helps guide surgeons in terms of what sorts of excisions might be needed, how to approach it. And then it has different criteria for endometriosis found on the diaphragm, adenomyosis, so sort of endometriosis in the womb itself, and which can cause some plaques outside the womb, and then extrapelvic outside the abdomen, either in the lungs, in the thorax, on the kidneys, on the liver, all those kind of things as well. Other scoring systems exist. Mostly, I think the thing people would have heard of would be the Endometriosis Fertility Index, which is useful when people are going through fertility assessment, or even when they're not, to give a judgment as to how likely people are on an individual basis to be able to fall pregnant without needing assisted reproductive technology, so IVF essentially. It looks at different criteria. So half of it looks at the patient history. It doesn't talk about the endometriosis at all. We know that one of the most important factors in subfertility is age. So it gives you a score based on your age. It gives you a score on whether you've previously been pregnant. And it gives you a score based on the duration of how long you've been trying to fall pregnant for. knowing that the longer you've been trying to fall pregnant for unsuccessfully, sadly, you get a bit of a law of diminishing returns, and the less likely you are, therefore, to be able to fall pregnant spontaneously afterwards. And then the second half looks at the endometriosis, and it looks at different areas, the ovaries, the fallopian tubes, the adnexum, which is what we call that whole area around the pelvis, mostly how functional they are in terms of scar tissue, whether the ovarian, the fallopian tubes are free and open to allow the passage of embryo and sperm and egg down to conceive effectively.
Okay.
Why don't you take a break, grab a snack, or go get hydrated, and we will be back in 15 seconds.
Okay, so let's talk about how you specifically diagnose endometriosis.
So officially, and this is what you'll find in the textbooks and things, you referenced it already, what we call the gold standard diagnostic model is doing a laparoscopy and visually inspecting the pelvis and seeing endometriosis. That is still the headline, but I think it goes a little bit further than that. We're going to get onto it in a second when we talk about the different colours and how endometriosis looks. But we know that we don't always get it right, and all gynecologists don't get it right all the time. And even probably the best, most skilled, most experienced gynecologists don't get it right all the time on visually inspecting endometriosis. So we'll add a bit to that and say, actually, doing a biopsy and confirming it in the laboratory. So looking at it under the microscope and saying, we've got this characteristic endometrial glands and stroma. Where was the biopsy taken? It wasn't from the uterus itself. We've got endometriosis. So that is the true gold standard, the real way of saying, have we got it, have we not got it? Of course, the only way to fundamentally say 100% is to biopsy everything. And actually, you're not necessarily going to be biopsying things that look normal, but it might be that quotes unquote looks normal, could well be there's some endometriosis there. So it's reasonable to biopsy anything that looks even remotely suspicious. So even if the surgeon says, I don't think this is endo, it could be inflammatory, it could be scar tissue from something else, let's still do a biopsy. And actually, you'd be surprised how much of that comes back saying it is endometriosis after all. But that isn't really how we diagnose it day to day necessarily. That's how we get the final nail in the coffin. We've got this diagnosis, you have got endometriosis. But we can be highly suspicious right from the beginning. So it goes to taking a full history from the woman suffering from the symptoms. You know, does she experience painful periods? Is the pain actually not exclusively cyclical? Is it happening throughout the menstrual cycle? Has it been a chronic pelvic pain of some duration? Does she experience pain during intercourse? If she does, is that a superficial pain? Is that a deep pain? Does it depend on certain positioning that might be causing aggravation of certain structures in the pelvis? And one of the features of deep infiltrating endometriosis, particularly that in the rectovaginal septum, is this thing called dyschezia. So that's significant pain when going to the lavatory, when opening your bowels, and also an urgency when you need to go for a poo, you need to go quickly. All of those features put together to say, well, actually, you know, if you've got all four of those, come on, we're going down that road of thinking endometriosis. We'd be surprised if it wasn't. So then you might go a little bit further and say, well, do you have a family history of endometriosis? We know that it exists more commonly in women who have a first-degree relative, so mothers, sisters with endo, and to a lesser extent, second-degree relatives. So those are important questions to ask. Going back to theories of how it started, that retrograde menstruation theory is still quite prominent and, you know, still undoubtedly has a part to play. So women who had earlier start of periods or shorter menstrual cycles, so essentially they've had more periods in their life, are shown to have a higher risk of endometriosis as well. Again, there's a bit of a chicken and egg thing perhaps there, but it's a reasonable question to ask. And then looking at characteristics, we know there's an inverse relationship with BMI, for example. So it's more likely in women with an underweight or healthy BMI than they are in the overweight category. Those are all questions. You then go on to doing some examination. You might find there's tenderness on palpating the pelvis, and women listening have probably experienced either speculum examinations or what we call a bimanual examination, which is a digital assessment of the pelvic organs. And there would be characteristic in some women thickening and tenderness along the uterosacral ligaments, so just behind the cervix. There might be a lot of pain and tenderness when moving the womb. There might be a great big nodule that you can feel that's tender. It might be that the womb doesn't move at all because it's so stuck down with all these adhesions, or you can feel a large ovarian cyst on pelvic examination. So that would lead you to suspect, well, putting all this together, all these symptoms, the history, the way the patient looks, the family history, and what I've seen on examination, I'd be even more surprised if this wasn't endometriosis. Of course, there are other things to consider, and you've got scar tissue because of previous infection. You've got lots and lots of different flavors of ovarian cyst, most of which entirely benign, reassuringly, that can all cause similar symptoms. And sometimes we simply don't have an explanation for this symptom, so it's not cut and dry at this stage. The next step would be doing some investigations. First line, we talked about doing a pelvic ultrasound scan. If you've seen what looks like an endometrioma, which has quite a classic appearance on an ultrasound, that's the chocolate cyst within the ovary. The likelihood of having endometriosis at that stage is pretty high indeed. Ultrasounds nowadays are better than they have ever been, and I'm sure they'll get better over years and decades to come, but the sensitivity and what we call the specificity, so saying what it really is, for endometriomas is pretty high now on ultrasound. They might also see features suggestive of the deep disease, either a nodule or evidence of scar tissue, which again raises your suspicion. The CA125 blood test isn't 100% a prerequisite for diagnosing endometriosis. So, I wouldn't worry if you're a patient going through investigative process and you haven't had that blood test. If the CA125 is mildly elevated or, a little bit higher than normal, that again is suggestive of endometriosis, but a normal CA125 doesn't entirely rule it out. A very, very high CA125 could be suggestive of something else going on, but it could be endometriosis as well. So it's a reasonable one to have. The next step really is done when you've already been referred to the hospital and you've come to either a district hospital, potentially endometriosis centre like we are in Chelsea, where really we're operating on deep infiltrating endometriosis, that ASRM stage 3 and 4 particularly. An MRI is useful in telling us a bit more about what the relationship is perhaps of these nodules with the bowel and the pelvic sidewall, the ureters, and that's often the emphasis of our discussion then is, yes, we've got the option of removing it surgically, but what is the potential risk involved with that? Do we need to involve other groups of surgeons like the urologists or the colorectal surgeons, who are our most common collaborators, to do some operating on the bowel? Do you need to shave the endometriosis off the bowel, or are we looking at actually resecting an area of bowel, or much less likely, but necessary under some circumstances, resecting bowel and giving a colostomy bag, what we call a stoma, to allow the bowel to heal before putting things back together again to normal. So all those things are considered. But you're right, the diagnosis, headline diagnosis, is laparoscopy, biopsy, confirmation under a microscope. But actually all of that process leading up to that, you're highly suspicious under some circumstances. Most of those symptoms are going to be there in someone with severe endometriosis when you put everything together. But actually in superficial peritoneal deposits, it might not be. We know it doesn't show up on ultrasound scan. You might not have all those symptoms together. And the CA125 is unlikely to be changed in MRI, usually doesn't show anything. So in that sense, you need to do all of the previous ones and then finally get to a laparoscopy to get the diagnosis yes or no. But in the more severe cases, you probably can know about it beforehand.
Okay. So, so basically I love the holistic, if that's the right word to use, approach you use, that you take the history, you do all of that before then going into laparoscopy. And I think
absolutely. I think the history is incredibly important, not just to elicit the symptoms, but actually to elicit what's going on in the patient's life, and how does she view the symptoms, and what are her priorities for things? Is the priority the pain? Is the priority getting a diagnosis? Is the priority fertility? What else has she got going on? Has she had previous surgery for other things which change the risk involved with this? Has she got a family member, under severe stress and strain? Is she suffering from mental health problems? So the history isn't just specific to the endometriosis, but actually we can learn a lot about it from there.
Okay. So talking about peritoneal endometriosis, I once read in a study that physicians were asked to identify endometriosis, and quite a significant number of them missed endometriosis. And this is because endometriosis can appear in various colors. So we can have black lesions, white, other lesions, and so on. So let's talk about the different appearances and colors of endometriosis.
Yeah, I think the first episode you mentioned endometriosis was an enigma, and it's an enigma even to gynecologists who devote their professional life to it. So you're absolutely right. It looks different. The classic appearance is what we call the powder burn, black or bluish hue deposits on the peritoneum. And I'd suggest anyone to put that into Google, and you'll see lots and lots of pictures from laparoscopies demonstrating these little spots. They're not often huge. They're, you know, up to a centimetre sometimes across, occasionally bigger, usually come in patches of, you know, 4, 5, 6, multiple little deposits. It can, however, look quite different. And I think these are the ones that trick people. These are the ones that trick even experienced surgeons who are very used to looking at and treating endometriosis. But you talk about the red or clear cystic looking endometriosis, which could be confused for bleeding areas of blood vessel, new blood vessels forming, areas of previous infection, or small little adhesions perhaps. Which again are seen, they talk about 30% of endometriosis having that appearance in some studies they've looked at. The other one is the white endometriosis, which probably is scar tissue that's formed as a result of previous inflammation going on in the area. The body's sent all these inflammatory mediators to the site, and the cell type around it has changed, and the peritoneum has become thickened and fibrosed, which gives it a whitish appearance, but there could well still be active endometriosis in it. And that's seen probably in about 20% of endometriosis, you know, looking at one study which was quoting on thousands of surgical cases. The red ones and the white ones are the ones that trick people, and it's the ones that, you know, surgeons get wrong. And if you can look at it and say, well, is it endometriosis, is it not endometriosis, not quite sure, the answer is biopsy it, for goodness sake, remove it anyway. It might not be, but equally it could be. There was a large study which found that 10% of lesions removed at surgery that the surgeon didn't think was endometriosis was endometriosis.
Wow.
So there's a possibility there. It also found that in lesions that the surgeon thought was endometriosis, around about 30% turned out not to be. So, you know, it's tricky. It's tricky. We talk about it in terms of a positive predictive value and a negative predictive value. If the surgeon says this is endometriosis, what are the chances of it being positive? And this study, one study I appreciate, but it was looking at quite a reasonable cohort, found that 64% were positive that were thought to be, and the negative was 88. So if it didn't look like endo, the surgeon said it wasn't, then it probably wasn't, or it wasn't in 88% of cases. Interestingly, this study was only looking at women that they saw lesions in the pelvis that they thought were endometriosis to a degree to start with. So they thought endometriosis was somewhere, and it was another lesion that they looked at that turned out not to be, they didn't think it was. So this study was not including women where they didn't see anything. So if you did a laparoscopy and you didn't see anything, it all looked totally normal. There wasn't even a red area, a white area, a sky blue pink area, then you probably haven't got the endo, because, you know, there was nothing even remotely suspicious there to biopsy. The answer is gynecologists should be biopsying absolutely everything. I think they do, you know, universally. We want to know, and I've been surprised in the past about what comes back as being endometriosis or what comes back as not being endometriosis. The confusing areas sometimes happen in women who've had previous surgeries. So they've had either excision or sometimes ablation of endometriosis. And then you see a scarred area. You sometimes see a little bit of charcoal area, which looks like a little black deposit as well. It might not be active disease. It might be where it was previously excised. It could be new disease growing into an area of previous excision. So there's a few question marks over it. But the answer is, if it looks a bit suspicious, you should probably be removing it, biopsying it.
Testing it. Okay. So there's a hashtag in the endometriosis space and community online known as hashtag extrapelvic not rare. Many on social media use this hashtag to try to highlight the existence of endometriosis outside of the pelvis. So let's talk about locations and sites of endometriosis. Research has shown that endo has occurred in all organs of the body apart from the spleen. So can we talk about where, first of all, in literature, where has endometriosis been found that people should be aware of? And also in your experience, what is the strangest organ or place that you found endometriosis?
Yeah, absolutely. We see it outside the pelvis not infrequently. You know, it is most commonly in the pelvis. So it is, you know, true to say that it's rarer outside the pelvis, but, you know, not rare. If we look on a global outlook, how many women are going to have extrapelvic endometriosis? We're talking about hundreds of thousands, millions potentially. So, you know, it's not rare in that sense. You say it hasn't been found in the spleen. I must admit, I've not read any literature saying it was found in the spleen, but I'm sure if you looked at enough spleens, you might find it somewhere. So who knows? I think we talked about this in the first episode, didn't we, about the other theory of endo. We talked about the malariosis. We talked about retrograde menstruation. The other one is that it's either a cell elsewhere in the body just fundamentally deciding one day it doesn't like being a bit of diaphragm or a bit of lung, it's going to become endometriosis, or it's endometriosis spreading through the blood system or through the lymphatic system and depositing elsewhere. So it's starting off in the womb or in the pelvis, and then it's appearing elsewhere. We don't know the answer fundamentally. The fact that it's been seen in men suggests that there is an element of what we call metaplasia, so changing of a cell from one cell type to another. We see it most commonly in the diaphragm when it's not in the pelvis. You can look at that on laparoscopy. That's probably why it's the most common one we see, because we're there and we're looking for it. If we did thoracoscopies and looked down in people's lungs and bronchi in every patient we did an endometriosis laparoscopy on, we might see it there as well. But we don't, because that involves significant risk, and people really wouldn't thank us for the side effects. So the diaphragm, it's seen. In the lungs we see it. There is a phenomenon called catamenial pneumothorax, which is endometriosis involving the lung tissue, such that during menstruation, when the endometriotic cells are inflamed and angry and causing bleeding, you might find the lung collapses. So that's a pneumothorax, and air fills the space where the lung was, or something called a hemothorax, where blood fills the space the lung was. And that can be really quite dangerous. That's something we were talking about at the beginning of the COVID pandemic. We did a webinar with CCMIG and talked all about the risks associated with endometriosis and COVID-19 and vice versa. Mostly we were able to reassure women actually that those suffering from endo are in a relatively low risk group, in that they were young and female and normally not otherwise unwell with chronic medical conditions, although not exclusively. But in those women who did have endometriosis in the lungs, in those women who did experience collapsed lungs during periods or were at risk of that, then potentially COVID is something that they should be addressing more carefully. It's difficult to say what the true prevalence is, because we don't look for it in everyone. We simply can't look for it in everyone without putting people at some increased risk. It's also true that some women get symptoms associated with endometriosis that might not be due to it. So shortness of breath, perhaps, or aches and pains in the chest. It could well be that there is an element of extrapelvic endometriosis. It could be associated with other hormonal changes going on. So we don't know 100%, but the lungs is probably a site that we all need to be aware of, particularly as being common. In my experience, beyond the diaphragm and the lungs, we do see it in the tummy button reasonably often. Sometimes it's after surgery. So we might see someone who's had laparoscopy surgery, or they've had a laparotomy. So that's a bigger scar on the tummy that's involved the tummy button, and they have an endometriotic lesion there. Sometimes they're under the skin and you can just feel a nodule or a lump. Often it gets more painful, it gets bigger during menstruation. Sometimes they're superficial, such that people actually have bleeding through their tummy button. So every time you have your period, you're bleeding through the tummy button, which, you can imagine how frustrating and difficult those sorts of symptoms are. In women who've had children delivered by cesarean section, we do see endometriosis in the cesarean scar occasionally. And this is sometimes seen in women who don't have any evidence of previous endometriosis. So it might be in the process of opening the womb, which you have to do to meet the baby. You're making an incision through the uterus, all the way through the muscle layers of the womb and through the endometrial layer, the decidual layer in that case. And the cells get out and they can deposit in the scar and potentially cause endometriosis there. Again, it is more commonly perhaps seen in women who have pelvic endometriosis otherwise. There's a patient I'm thinking of who we were looking after quite recently who's got endometriosis potentially in the site of a previous hernia repair. So a hernia in the groin that was repaired, and that gets more painful, more swollen during the menstrual cycle, and there's endometriosis there. There was a very interesting case some months ago that actually was being operated on at a hospital in Chelsea, one of the private hospitals that we've been operating on during the pandemic, called the Lister Hospital. But she was a patient from down in Surrey, looked after by Mr. Kazali, who had endometriosis involving the nerves supplying her buttocks and her leg, such that the MRI pictures that we looked at, all the muscles on that side had shrunk away and wasted, just like someone would have if they'd had a spinal cord injury or a stroke or something like that, because the endometriosis had affected the nerves and the muscles in that way, and that involved surgical excision. So that was not necessarily it was related to pelvic deep infiltrating endometriosis, but it got so far, it got beyond the normal pelvic structures we talk about being involved. It's been found in the brain. It's been found all sorts of places. Sorry, Tenny.
No, I was going to say, could she walk?
She was finding it increasingly difficult. I must admit, I didn't meet the patient myself. I was around in the hospital at the time she was having her surgery, but I don't know how severe her symptoms got, such that she might not have been able to walk. But I know that was a significant symptom. Her legs were getting weaker, the muscles were getting wasted. I think her mobility was getting harder and harder. It was recently reported in the press. I think the Independent talked about it, so it would be there on Google if anyone wants to look it up.
And you said it has also been found in the brain.
It has been, yeah. These sites are probably much rarer. So although extrapelvic endometriosis might not be as rare as we think, these sort of extraordinary sites are indeed rare. And I would say that neurological involvement to the brain or large nerves in the body is a very rare phenomenon, but not zero. They would probably present with neurological symptoms, headaches, weaknesses, tingling in limbs, those sorts of things. And of course, if those sorts of things happen, it is perhaps far more likely it's another diagnosis. But in a woman who's known to have endometriosis, that affects non-pelvic sites, it would be on the list of differentials when she was being looked after.
So final question, and this is about another rare manifestation of endometriosis. It's something I've been wanting to talk about because I have personally experienced this rarity, and I'm keen to make sure that people are aware that it exists. And this is ascites, so hemorrhagic ascites due to endometriosis. It's been said that it's rare, but what's pretty interesting is I was on a webinar hosted by an endometriosis advocate in Nigeria, and she had some doctors on the panel, both from the UK and also from Nigeria. So I asked the question about ascites, and I wanted to know how many of the cases they had actually come across. So the doctors in the UK said it was indeed rare, and I think one of them had not even come across it at all. But the Nigerian doctor said that he's also an excision specialist, and he said he has seen quite a few cases. So the more I talk about it with people, I think it would help to raise awareness, and we'll begin to see the condition in the literature. So let's talk about ascites, what it is, why it happens, if we know, because with endometriosis, we never know. And if there's any thing in terms of race or, that predisposes people to having ascites with endometriosis, because I'm not sure.
Absolutely, yeah. So ascites, first of all, describes fluid in the abdomen, in the intraperitoneal cavity. So that's the area that contains your large bowel, your small bowel, your stomach, spleen and liver. All your pelvic organs are all intraperitoneal. The kidneys, interestingly, are retroperitoneal, so they're just behind. And the retroperitoneum is where the deep infiltrating endometriosis invades into. So lots of fluid inside the tummy, basically, is ascites. It can happen to either to lesser or greater degrees. A small amount of fluid is very common, actually. It usually happens classically in the middle of a menstrual cycle. We do a laparoscopy and there might be 50, 100 mils of fluid in the pelvis. Sometimes it's a little bit bloody, and that can be due to the follicle that released the eggs, sometimes having a little bit of bleeding from it, or it could be an element of retrograde menstruation, depending on whereabouts in the cycle we are. So that, in a sense, is normal. What isn't normal is large volumes of it. And we know that ascites can get into the many litres. And I think you and I, Tenny, were talking about your recent ascites, and was it 5 litres?
5 litres. And this
drained
time I had 5 litres drained, so.
Which is a huge amount. And you would have undoubtedly felt, really symptomatic with that. Bloating and swelling of the tummy, and it definitely wouldn't have looked normal at all. This might be, to a lesser degree than 5 litres, go somewhere in explaining the sort of endobelly appearance that people get, perhaps, that swelling characteristic. Some of it might be hormonal in terms of the bowel slowing down and more gas building up. So there's different potentials, but it perhaps plays its part. But this severe ascites, which is, large volume, lots and lots of fluid, classically with blood all mixed in, the endometriotic fluid, as a manifestation of endometriosis is rare. Absolutely. It's something that I've not personally experienced. I'm at the beginning of my career as an endometriosis doctor, so you perhaps might not have expected me to experience the rarer things, but you could quite happily, as you said, speak to doctors who've been doing it for 40 years, at least in UK practice and Western Europe, who wouldn't have seen it either. The literature, in fact, and I looked up just before we had this conversation, there are 64 cases reported in the medical literature of severe ascites attributable to endometriosis. Of course, there would have been far more. That's the very tip of the iceberg of cases that are either extraordinary or interesting or worthy of writing up, or had doctors with the wherewithal and interest to write it up. So, that doesn't necessarily represent things, but it tells us it doesn't happen all the time. By far and away, the biggest risk factor noted in that case series was being of Afro-Caribbean origin. So it probably isn't a huge surprise that the doctors who are working in Nigerian practice saw it more commonly. I suspect it's still rare for them, but it's something they would have all experienced throughout their careers. Whereas in the UK, it might not have been. And it's still certainly worthy in the UK of writing up in the medical literature, so people like me and patients like you can read about it and learn about it. It's often pretty scary when it happens because, number one, it's very debilitating, very painful, huge amounts of discomfort. Number two, ascites can be associated with other things and things that can be, including cancers of the ovary. If you were to find an endometrioma, a complex-looking ovarian cyst, you were to find large amounts of fluid in the abdomen and pelvis, so ascites, and you were to do a CA-125 blood test, which undoubtedly in the context of large amounts of endometriosis ascites would be raised, your first thing to rule out would be cancer of the ovary. And that's got to be incredibly scary for someone going through that. So these are women who usually would present through our cancer meetings and then come to us in endometriosis as a second port of call, unless we know that they've had endometriosis for some time. We know that this is a manifestation, sadly, of their condition. So yeah, it's rare, it's very symptomatic, it can be extremely debilitating. It is much more common in women of Afro-Caribbean origin. In the case series that we were looking at, I think it was 70% or so were Black, but it might be due to the resource limitations and limitations on medical expertise in Sub-Saharan Africa particularly. It's probably overrepresented in terms of the white population, so it's probably more affecting Afro-Caribbean people even than the literature suggests, due to what we call a publication bias. So if it happens to you in wealthy UK, it's more likely to be reported and written on in the medical literature than it happens somewhere much more rural and developed and undeveloped, to beg your pardon.
Yeah, I agree. I agree with that. So thank you very much for those answers. It's been a great episode again, and I'm looking forward to next episode where we'll be talking about the different treatments of endometriosis. So talking about hormonal, surgical, and even holistic therapies. So I'm looking forward to that for next episode.
Excellent. Yeah, no, don't mention it. There's huge amounts to talk about, as I said, and every answer we can go into far more detail and go down different tangents and avenues. Because it is a real enigma. There's huge amounts we don't understand. It's a hugely complex issue, and it's hugely debilitating. But I think the more that we talk about it, the more that women know about the possible symptoms and they know about possibilities of investigation and treatment, the better.
Okay, amazing. Thank you so much, Tom. See you next week.
Don't mention it. See you next week, Tenny.
Okay. I hope you've learned a lot from this episode today. Be sure to come back next week for episode 3, where we talk about the different treatments for endometriosis. If you enjoyed this episode, I would love to know. Join me on Instagram and Facebook, and also follow the Instagram page of Chelsea Center for Minimal Invasive Gynecology at ccmig.london, where Tom shares a lot of relevant and helpful information on endometriosis. Don't forget to share, rate, and subscribe to this episode. Till next time, remember, you are not defined by endo.
Thanks for listening. Be sure to come back next time.